Oh, thank you for my colleague who just spotlighted me, since apparently you can't spotlight yourself. So good morning, and thank you for joining us for the second and final day of Foundations, Contextual Dimensions, and Practice of Addiction Medicine in Adolescent through Transitional Aged Youth Education and Medical Necessity. I'm Elaine Densley, and I serve as the Administrative and Program Manager for the Virginia Tech Richmond Center. We're delighted to be providing the virtual program management and technical support for this training. At this time, I'm going to cover a few housekeeping items. I know we did it yesterday, but just to be on the safe side, this is a Zoom meeting, so we encourage you to leave your camera on, but be sure to remain muted unless invited to ask a question. So we do want you to interact with your fellow participants and the instructor by utilizing the chat. Dr. Fishman will have Q&A throughout the session today, so please add your questions to the chat or use the reaction button at the bottom of your screen to raise your hand. Additionally, if you should have technical issues, my colleagues are here to assist. So look for the names in the list of participants that have a VT at the end. It doesn't mean we're from Vermont. It means we work for Virginia Tech. Just send us a private message. We have a busy 2 hours today, so feel free to get up and stretch as you need, but we do plan to have a 10-minute break about halfway through. It'll depend on the timing of the slides and how Dr. Fishman is running. We have shared Dr. Fishman's presentation. It was in the Know Before You Go email that you received, or you can click on the link in the chat that my colleague Rachel is putting in the chat. Well, she's putting it in currently. I can't see the chat, so I'll have to assume she did it. CMEs are being given for this training, so please be sure to rename yourself to include your first and last name. This allows us to attract attendance and ensures that everyone gets the correct number of CMEs. This can be done by right-clicking on your name on the screen and selecting Rename. Please also watch the chat for a message from the Virginia Tech team regarding your name display or your registration status. In order to receive CMEs for this training session, not only must you be properly named so your attendance can be recorded, you must be registered for the program. If we contact you and let you know that you are not registered, please provide the information that we request and we can be sure to get you registered so that you can get everything that you deserve for this training session. Wait a minute, there's one more thing you have to do. You have to complete an evaluation. So if you attended yesterday, you need to complete the evaluation for yesterday, and then there's another one for today. Those will be provided in the chat as we near the end of the session and in the follow-up email that you'll receive this afternoon. Thanks again for joining us, and I will turn it over to Dr. Fishman.
Terrific. Well, good morning, everyone. Thanks for being here. Thanks for coming back. And we're going to start where we left off. If you remember yesterday, we were going through the ASAM assessment dimensions one by one, and we went 4, 1, 2, 3. And so today we'll spend the first half of our time or thereabouts looking at dimensions 5 and 6. Dimension 5, relapse continued use potential. Dimension 6, recovery environment. With a focus on family involvement as such an important component of recovery environment for young people. And then we'll spend about the second half using a case example to get into the weeds of placement and treatment planning, applying some of the more general principles that we've started to work with. So, without further ado, dimension 5. And here are some elements of a relapse continued use potential assessment. And you may not get all this detail the first time you meet with someone. A youngster, especially young people, may not have the psychological mindedness and introspection to be able to give you all this information. But this is kind of a template for some of the things you'd like to know. You want to know the deets about what exactly they're using, how much, how frequently, how long it's been going on, how has it changed, up or down, have they cut back in the past, why, how has it happened? And then you want to know about the drugs that they use, the substances they use. How does it affect them? What do they like, not like about it? What are the things that they seek about using? Why do you use that? What does it do for you? How does it make you feel? both in terms of the reward craving, and that is that kind of euphoria, the getting high, how does it make you feel good? But as importantly, or maybe even more importantly, as a feature of more advanced addiction as substance use disorder progresses, the negative reinforcement, meaning the relief craving. You know, people talk about, I'm not so much feeling good anymore when I use, I'm just trying to feel normal. I'm just trying to relieve stress. I'm just trying to get well. That's in particular people who are cognizant of withdrawal symptoms. That's a characteristic statement of somebody with advanced opioid use disorder, for example. Just trying to relieve my withdrawal. I'm just trying to get well. I'm still chasing that first high that I can't nostalgically actually achieve. But even if they don't articulate it in that way in terms of explicit relief from withdrawal, you will, as you get to know a young person, be able to sense that there is a self-soothing phenomena, there's stress relief, there's coping. I think some people talked about that. And so we want to know those things, and these are then helpful in understanding what makes them tick in terms of their drive for continuing to use. And then those are elements that need to be addressed, both psychologically and perhaps also pharmacologically. Response to triggers, and triggers come in internal flavors and external flavors. External flavors are the persons, places, things, the cues, people you use with, the places you go, those you hang out with, where do you get drugs, what are the contexts in which you use drugs, whether you know it or not. Lots of times you will hear people describe triggering external stimuli or cues that are so obvious to us, and they say, well, I don't get it. What does that have to do with it? I don't feel a craving. I just use when I'm around Joey. Well, then isn't Joey a trigger? No, Joey's just my buddy. Okay, fine. But we make that connection. And then internal triggers having to do with internal emotional states. Back to ideas of negative reinforcement. Is it anger? Is it irritability? Is it arguments? Is it stress? Is it depression? Is it anxiety? Is it recollection of past events that bubble up and cause psychological distress? But all of these things are things that often take a person a while to figure out, but as we understand them and assess them and catalog them, they give us targets for informing treatment. And then characteristics of the person, right? There are differences in temperament and psychological makeup, both resilience and vulnerability, that characterize different individuals, different young people. And so thinking about cognitive and behavioral strengths and weaknesses, that's a synonym for vulnerabilities and resilience either way. And for many young people, these are developmental in their origin. Certainly they can persist into adulthood, but we also, as we talked about, think about this as a developmental issue for immature young people who are not fully baked and out of the oven. And some of the characteristic of things, although there'll be variation, but characteristic things that we hear about from young people is I'm invincible, this doesn't apply to me, that won't happen to me, that happens to other people, weak people, but I'm fine. We will see that they may be immature relative to older adults, have poor coping skills, and for sure have less life experience, less independent living experience and expertise than older adults, but they might not recognize that because it's developmentally normative as you are transitioning from childhood to the teen years to young adulthood, to want to have a foot in adulthood and to want to think of yourself as all grown up and mature and want to have pushback against what you see as the intrusive and restrictive dependence on adults, family of origin or whatever. And so there's a totally normative tension there between feeling all grown up, but as we recognize it, not being all grown up. So these are elements that help understand a young person and help inform some of the treatment targets for relapse prevention and understanding severity in this dimension. So important to conceptualize the idea of lapse and relapse. That distinction, there's no bright line, but we like to think of lapse as the idea of using despite the pursuit of treatment and recovery and an occasional dip and dab and episode of return to use after stopping. You got to stop to have a lapse, but if you stop or cut down and then increase or use, a lapse may or may not return to a full pattern of enduring frequent use, which we call a relapse. And lapses can turn to relapses or may not. And if we discover them early, we want to prevent full relapse. But it is the norm to have lapse and relapse. We say that relapse is part of recovery, not that we're condoning it, not that we want to give people permission to go off and use willy-nilly. Of course, we're asking them not to, but we're not surprised when it happens. We're not surprised that it isn't a unilinear direction and trajectory of recovery, that it's 3 steps forward and 2 steps back. And lapse and relapse are not an indication of personal failure. Lapse and relapse are not an indication of treatment failure. They are, unfortunately, and sometimes tragically, an element of the course of this illness. And as I say, although we don't want to encourage it or normalize it to the extent that we think it's a good thing, we do want to normalize it so that people are not shamed, so that we don't have a punitive attitude, so that we can encourage honest reporting. We don't want to drive it underground if it's going to happen. We want to know about it. We think, in fact, that it is a good prognostic feature of treatment response in early recovery for people to tell us that they are worried, to have people learn to be able to articulate internal and external triggers and to articulate internal dread or anticipation of temptation and craving. That's counterintuitive, right? Patients at first don't want to say that because that makes them seem like failures, because we will criticize them, because they'll be in trouble, because we'll hold them accountable for needing a higher dose of treatment. But we want them to be able to say, I'm nervous, I'm in trouble, or I did this thing and I don't feel great about it, and help me not do it again. Those are good prognostic signs. Those are helpful in treatment, and we want to encourage that. And when relapse and relapse happens, again, these are not grounds for dismissing people from treatment. That is mostly, I'm pleased to say, a feature that has faded away in most treatment service delivery, but not entirely. But it used to be pretty standard. When people continued to use in treatment, they were fired from treatment. But why would you send a person away from a treatment for being ill? That's why they're in treatment, that they are prone to use. We want to encourage treatment. That's all the reason they need more treatment. So the response to lapse and relapse is not that you're punished or that you're bad, but it's, what are we going to do different? How can I get you to be forthcoming about this and look for a different response? That, by the way, although we don't necessarily have time to go into the details, is a skill that more seasoned clinicians learn in terms of the valuable use of urine drug testing. So just a word on that. It's a very valuable tool that we use. Trust but verify. We want to ask people what's in their urine and get them to practice being honest, since they're going to learn that we have another way of verifying. So why not tell us? We won't be mad. But it takes some discipline and some practice for clinicians to not use a positive urine drug test result as a gotcha moment. That's not helpful. Not to have a fight about, I don't know how that got into my pee. Oh, where'd that come from? Oh, I don't know. The person in the next county must have been smoking next to me. That's where that probably came from. It wasn't just secondhand smoke. It was 12th hand smoke. Yeah, all right, whatever. I'm not going to fight with you about it, but I want to use it as an opportunity to troubleshoot the fact that this did happen, or if you don't want to admit that it did happen, that it could happen. We'll look for a trend. Fine, any drug test can be a mistake. We'll do it again. We're looking for patterns, but get out of the fight and into a planning operation of what can we do to help you. Now, in particular, in Dimension 5, I want to shine a lens of focus on opioid use disorder. Again, not because opioid use disorder is the most common substance use disorder among youth, right? That's going to be alcohol and cannabis and nicotine, et cetera, as we've discussed. But it certainly is so dangerous. And it also happens to be a particular subtype, a particularly advanced and malignant subtype of SUD. But it happens to be a subtype in which we have some very powerful, effective, helpful relapse prevention tools, namely the medications that we use for relapse prevention in OUD, sometimes called MAT, medication-assisted treatment, the more modern jargon being MOUD, medications for opioid use disorder, whatever you want to call them. The 3 FDA-approved medicines that you know are methadone, naltrexone, usually used in extended release formulation, brand name Vivitrol, and buprenorphine, typically brand name Suboxone, also available in an extended release injectable form, brand name Sublocade. Anyway, these are the cornerstones of medication treatment for OUD, and they are effective, including effective for youth. And so important to highlight them in any discussion of relapse prevention. And here is just one of many, many studies that remind us how effective these medications are in youth. This is a big multi-state Medicaid claims data set looking at 5,000 or so young people, young adults and adolescents who had diagnoses and insurance claims for OUD, and comparing those that received medication to those that did not receive medication but got treatment with counseling or therapy only. And the graph shows us this is a survival curve of retention out to about a year, and getting medication substantially increases retention in care and decreases dropout. And not just retention in medication treatment, but retention in counseling treatment. This is all treatment. And so you don't have to choose. One of the early criticisms is people were struggling, medicines, not medicines, is gosh, if we give them medicines, they won't want the other critically important elements of treatment that we give in a holistically delivered full package, the counseling, the therapy, the meetings. Well, on the contrary, you can have your cake and eat it too. If they get medicines, they go to more groups. If they get medicines, they come to more counseling sessions. So this is so important. Now, the downside here, that's glass half full, glass half empty, is that there is remarkably poor uptake and dissemination. So only 76% of this group received any kind of treatment at all, medication or behavior. And half of them did not get medication. And no, I'm sorry, 3/4 of them did not get medication. And that was 5% only got medication under 18. Now, hopefully this is older data. I think this is from 2018. So we've done somewhat better in uptake and dissemination, but nowhere near enough. So that's a major push in our field for the subgroup of young people that do have opioid use disorder, especially with the high potency and lethality of fentanyl out on the streets, that we push MOUD as an essential standard of care treatment element of our Dimension 5 tool chest. But if only it were that easy, right? If only we're just prescribing more buprenorphine or getting more buprenorphine prescribers or putting buprenorphine in the water. Not that simple. Buprenorphine is not curative. And as good as it is, young adults, as shown in this study, have worse MOUD outcomes compared to older adults. So MOUD, very effective in adolescents and young adults. But in this study of young adults, this is a secondary data reanalysis of the famous XBOT study. That was a very big landmark study of adults over 18, randomizing them to either extended release naltrexone or sublingual daily buprenorphine. And the main result, not shown here, of that study was that, won't surprise you, it's harder to get on naltrexone, easier to get onto buprenorphine. But once you get on either medicine, they are both about as effective for preventing relapse and aiding retention and treatment over the course of 6 months. Now, this data is not looking at the two medicines head to head. This is dividing the population up into older adults over 26 and young adults 18 to 25, both medicines combined. And the take-home message here in this survival curve of relapse-free survival, of non-relapse, is that among the older adults, 49% remained non-relapsed at the end of 6 months. So about half, that's a number we've been talking about 50% retention at 6 months. That's about the benchmark in research for adult MOUD for all the medicines. And for young adults, it was substantially and statistically significant less good. 34% non-relapsed at 6 months. Now, glass half full, that's way better than if there'd been no medicines. So that's still great, that's still life-saving, but it's not as good as older adults, and there's plenty of room for improvement. And again, we look to the vulnerabilities, mostly developmental vulnerabilities of young people, as presenting a problem in terms of adherence to medicines, in terms of retention in treatment, all the things we talked about and continue to talk about, and that you know about: immaturity, invincibility, this doesn't apply to me, I don't need your stinking medicines, I don't need to be in treatment, I got better things to do, etc. So what do we do about that? Well, one thing is to increase capacity for incorporation of MOUD into youth-facing treatment. Easy for me to say that. I know that Virginia and other places working very hard at developing that capacity. That's super good. And one of the things to think about are medication-forward approaches. For sure, we want MOUD, MAT, to be part of a full package of holistic multi-component treatment elements, including counseling and meetings and supports and co-occurring treatment and therapy and all those good things. But sometimes we need to lead with medicines. Sometimes we need to have lower barrier access to medicines and then add those other things as possible. And why do I say that? Why do I talk about a medicine-forward approach? Well, because of all the components for OUD, and they're all good components, and together they form a synergistic whole that is greater than the sum of the parts. But of all those components, MOUD is the single most effective component for OUD. And it is life-saving. And some youth are not going to readily accept the burdens of all those other components of treatment. They may be mistaken, they may be wrong-headed in declining those things, they may need them, but in order not to let the perfect be the enemy of the good, we advocate a medicine-forward approach, lead with medicine, get them to do more as they can, but the place to start is to get them onto medicine and to emphasize medication adherence as a practical goal and focus on it. And that means everybody stepping outside their lane, even if you're not the doctor or nurse, knowing something about the medicine, knowing about medicine benefits, knowing about medicine side effects, and making it part of your bailiwick, expanding your lane, putting into your wheelhouse medication monitoring and medication adherence. There are a bunch of different emerging care models that have been medication forward. There's somebody with some background noise, needs to mute, please. One is an assertive family-based treatment approach that involves family members, adult caregivers, parents, as being involved as partners in medication treatment for OUD. I'm going to show you an example of that when we get into family treatments that my group's been working on. The idea of integrating MOUD, MAT into primary care, sometimes supported as a spoke by a specialty hub that can do consultation, advice, training, technical assistance. A lot of primary care offices, pediatrics, and family practice are reluctant to get into the buprenorphine prescribing business. They don't have that many OUD patients. They're afraid that if they put up a sign that says OUD within, there'll be a line around the block and their practice will be taken over. They don't have the time, they don't have the expertise. It's not the idea to ask primary care folks to become specialty sites. It's to say, listen, you have these patients in your population anyway, you just don't know about it. And so just as primary care adds other components, it's difficult because you got a 7.5-minute office visit and you got a lot to squeeze in. So this is not trivial, but this is a way of asking family medicine and primary care pediatrics or internal medicine and family medicine for young adults. You're already treating these patients. Add this to your repertoire. It's not as hard as you think. Working on collaborative care consultation. This is a nice model where general practitioners or mental health practitioners who are not MOUD experts can get consultation from on-call or easily available subspecialists in addiction medicine or addiction psychiatry. The idea of going upstream to identify young adults who might present to the ED or to hospital or to psychiatric hospital or to the criminal justice system and getting them started in those settings on MOUD. And there are even some, these are not very common, but there are some school-based delivery systems. School-based delivery for SUD services broadly, mostly cannabis and drinking, are more common. But there are some programs that are adding OUD services with MOUD to school-based delivery, an innovative way of thinking about medication-forward approaches. All right, next we'll do dimension 6, which is a very big one in young adults. But before we do, take a moment for comments, questions, concerns.
Dr. Fishman, I'm going to drop a series of questions into the chat for you that have come in while you've been talking.
All right.
There you go.
Here's a question, where youth are being sent for detox in Northern Virginia for fentanyl detox, and I plead ignorance on local resources. And if there are people that can chime in and give us some guidance on local Virginia resources, that'd be helpful. Anyone? I know I've heard that this is a development in progress and that the state is working very hard to create these resources, but I can't tell you what's on the ground now. Anyone? All right, maybe we'll come back to that. Why multi-component holistic approaches are less attractive to
Dr.
some youth?
Fishman,
Yes.
as I know it, there for Medicaid patients, there are not any inpatient facilities at this time that are taking primary diagnosis of OUD. If they are having a psychiatric emergency, such as suicidal ideations or psychosis, they will take it as a secondary diagnosis. There are some private facilities, Sandstone, they're taking case by case, Dominion case by case, that are doing inpatient acute intoxication management, withdrawal, stabilization.
Good. It's good to know. And this idea of the workaround of taking folks who need detox, but may also have other comorbid problems, whether it's a medical problem like a consequence of injection drug use, a soft tissue infection, or whether it's a psychiatric consequence like suicidality or out of control behavior, and managing withdrawal in a short-term hospitalization and then transferring them to subspecialty SUD care, either residential or outpatient, is a workaround that many places have done. It may not be optimal, but it sure is better than nothing. So thanks for that. Why multi-component holistic approaches are less attractive? Well, treatment is burdensome. And it's not that those aren't good approaches. It's that lots of people would rather do less instead of more. It's not just young people, but it's especially young people. Think of all the things that your average young adult or teenager would rather be doing than going to treatment. And so it takes time, it takes commitment, it takes getting there, it takes logistics. Lots of patients would rather do the least. They're teetering on the edge of motivation anyway. And then we say, you got to come 3 times a week for 3 hours each, or you got to do whatever. so often lower barrier approaches that get them in the door, is my point, by just starting on medicines that can show them that you have something to offer and that can give them relief from withdrawal and protect them from overdose as a starting point, and then you're trying to reel them in for more. I'm looking here, here's some people saying about resources, thank you for that. Other comments, other questions about Dimension 5? All right, let's go to Dimension 6, recovery environment. And part of this is obviously family, as thinking about what are the potential supports or the potential influences on the recovery environment for a young person. So many young people are living at home, even through their mid and late 20s. Not all of them, but a lot are. And family influences, peer influences, neighborhood, community influences are so important, both positive and negative. That is, positive supports and negative influences. Is there use in the family? Is there an attitude against treatment or a disregard for treatment? We talked about the idea that lots of the culture and lots of families may be minimizing of the harms of substances, particularly alcohol, cannabis, and nicotine. So family values are important. We want to learn about them as part of the assessment, and we want to use them to good when we can. Now, there are some families that are so toxic that we think about separation. Families where kids are abused, families where kids are in harm's way of victimization, families where there is use with the family, right? I've certainly worked with families where they inject together. That's obviously a big problem. But in general, that's the exception. Those are the minority. For most families, there is a core of good. For most families, there are elements of positive support and things that you and I can't do. We don't have the connection. We don't have the enduring history. We don't have the familial love. We don't have the moral authority. We don't have the persuasion. And long after we're gone, these are still the families they're going to have. So anything we can do to improve the ability to take what's good and strong and core about family support and improve it rather than dismissing it, that's better. Elements of monitoring and supervision, elements of treatment support, including just the logistic basics, like how are you going to get there, who's going to pay for it, what's the scheduling, who's the grown-up in the house, that kind of stuff. But we got to assess that and know about it. Is there use in the household? Is there a romantic partner that's using? That's a very common theme with adolescents and young adults. My boyfriend, girlfriend, I use with them. But it can sometimes be the opposite. My girlfriend hates my use. My boyfriend doesn't use, and he's trying to help me. Peers and substance-infested communities, for sure. Just a quick look, at the culture. We've talked about this. These things are so common. It's no big deal. It's natural. We used it when we were kids. They should learn to drink at home. Every kid drinks a little beer. It's no big deal. And so these are elements that we have to contend with. And intoxication is such a theme in our culture. It's associated with the good life. It's associated with luxury. Turn on any pop music station, and it's an assault of the glorification of intoxication. Look at any movie, look at any video, look at the movie stars, the pop stars. You know the drill. And so counter messaging that is not trivial, but that's our job. Support for treatment or lack of support for treatment comes in different flavors. To what extent can we get families to be better about active support for treatment versus, at a bare minimum, neutral acceptance, but without ability to support? versus opposition or undermining, which we have to actively address. Hopefully that's the exception, but we need to assess and address these things. Just some of the fundamental basics that it's easy to overlook, but we need to do case management around. These families often are doing their best, but they've got jobs and other kids and burdens of their financial situation and divided time commitments, and it's difficult to get transportation, all of those things that you know about. And those aren't things that we immediately focus on when we're thinking about therapeutic goals, but they sure are important in terms of being able to accomplish the practical goal of implementation of treatment. What about families that may have use in the family? That's a pretty common thing. It may not be as malignantly toxic as injecting fentanyl together, but there's a wide spectrum of variation there. And household use is common, either from casual use or minimization of youth use or significant problem use. And when you suspect problem use, how do you address it? Because you don't want to alienate the families because you want them as allies. And they say, well, I'm not here for me. That's none of your business. I'm here for Johnny. How dare you say something about, you don't know me. Everybody drinks a little. What are you fussing at? That's tricky, right? And you haven't assessed them formally. They aren't your formal patient. It's a tricky business. There's no great answer to this, but let me tell you about an approach that I often try. I call it universal precautions. That'll be familiar to healthcare workers. You know, the idea that when we're thinking about infectious disease, we don't single out people who have a particular infection. We wear gloves and wash our hands with everybody because it's everywhere. Well, same idea here. So what I try to do is, listen, we're trying to get Johnny to use less or to quit. And remember, kids are mimics. They do what you do, not what you say. And I don't know you, and I apologize in advance. Some families, there's social drinking and social smoking and whatever. It's a thing, I know, and I'm not saying it's you. And I apologize for even having to bring this up. But when we're trying to get kids to cut down and quit, you know, it's sometimes helpful to create a substance-free house. And I know I'm asking a lot. And I know it's a burden. And I'm not saying forever. But if you can get it out of the house, just for now, that would be a big help. And you see, that's a way of having the conversation without trying to get them to be defensive, without saying it's particularly you, without insinuating that you have a problem. It's just that everybody with a kid with a substance problem ought to try to have a substance-free house. And sometimes that can be helpful. Sometimes it gets me punched in the nose, whatever, but you try. And they'll say the greatest, well, don't worry, Dr. Fishman, I lock it up. Yeah? Have you seen the lock that can keep a 16-year-old out? I don't know. But anyway, and at the very least, don't do it in front of them. If you can get nothing else, adopt a stance of this isn't something that kids should have eyes on. When working with parents, they often need coaching because by the time they get to us, they're up to their ears in alligators. They're embattled, they're fighting. They've tried a lot of stuff. They clearly love and care about their kids. They may be ambivalent about connecting the dots. Are their kids' troubles all or even mostly or even any connected to substance use? But for sure, they're wrestling over behaviors and mood and temper outbursts and all that stuff. And it is easy for them to jump to an authoritarian approach and a punitive approach. And that turns out not to be so effective, right? You know that. So one of the things that is so important as a Dimension 6 element and component of treatment is trying to work to engage families, and once engaged, trying to coach them on enhancing their parenting practices to be positive influences for treatment goals. Now, why is family engagement such a heavy lift? Why isn't it routine? We talk in our field about addictions of family illness. Everybody gives lip service to that, but the actual doing is another thing. It is really, I think, underdone. And that's in part because it's hard. It is not trivial. It's hard enough to try to persuade this ambivalent pre-contemplative kid to be engaged in treatment. And then I have other stakeholders as well. I got to work with this truculent mom, and I got to work with the probation officer, and I got to work with the social services person. Wow, it's a swirl of trouble. You'll hear me say again and again that I think the investment in parent engagement is worth it, but it's not trivial. And there's a bunch of historical reasons, I think, why the field doesn't do as good a job as it ought to. One, as we've discussed, is there's a normative pushback by kids about saying, I'm grown up. You don't need to talk to my mom. In fact, I don't want you to talk to my mom, and it's none of her business, and all she ever does is nag me, and what's the point? In general, our schools and training and job settings don't emphasize training and competence on family involvement, and so lots of clinicians are not comfortable with it. We have in our field a focus on internal transformation, internal motivation. People have to want to get better, and although internal transformation and internal motivation is important, it's not necessarily how people begin to change, especially young people. Lots of people, most young people, in fact, begin their journey of behavioral change through external motivation. And to use a cartoon, right? When you're trying to get a 5-year-old to hold your hand when crossing the road, you don't say, well, you've got to want to hold my hand. You don't say, well, fine. If you don't want to hold my hand, then don't hold my hand. Get hit by a truck. That'll learn you. We say, you don't have to want to hold my hand. You just have to hold my hand. And so that kind of oversimplified analogy is an example, though, of where we need to increasingly focus our thoughts about motivations for change as having external sources of motivation, including the influence of parents, rather than looking for insight, which is going to be late to the game, where epiphany and internal motivation is good, but it will be later. We have a focus in the field on enabling. So what is one, to the extent that we do talk to parents, we often talk to them about being too soft, setting up a rescue pattern that doesn't let patients, loved ones feel the consequences of their use. We ask them to know their limits and withdraw because there's nothing they can do. People have to change their own lives. You can't change other people for them. Some of that has validity. There is certainly a group of families where enabling is a problem, but I'm not sure it is as much the problem as we tend to think. And even more importantly than that, even if the enabling hypothesis is correct for some families, it's not a good message at the outset. Because when we talk about enabling, what do parents hear? Whether we intend it or not. They hear us scolding and saying it's your fault. And even if we don't mean that, that I assure you is what they hear. And that's not very welcoming. And that's not a way to encourage the best of parenting. And to say disengage, I think, is harmful. And, that gets me into trouble with the Al-Anon folks, where the core message is often let go and let live. And I find that problematic, especially for young people. We have had what I think is an over-rigid concern with confidentiality. Now, listen, confidentiality is a cornerstone of what we do. Confidential behavioral health services are so important, being able to assure people that we won't blab all over the bathroom walls about their business so that they can be honest to us. But I think we overdo it, and I think we're over-rigid, and I think that we can finesse this and figure out ways of including families that don't violate confidentiality. And the cartoon of problems with confidentiality is the classic story. Maybe it's a little over dramatic, but the classic story of a mom who's got a kid in treatment, kid's living at home, she's paying for the treatment, it's her insurance, she drops the kid off at group, she's in the parking lot, she's in the waiting room, whatever, she knows the kid's at the center doing treatment. And then she tries to ask the counselor, how's little Johnny doing? And what does she get? We can neither affirm nor deny that a person by that name is receiving treatment at this, again, over dramatic, but that's the message that some families get. And I think that that's problematic. So we need to work harder to engage families and to figure out how to deal with the confidentiality issue, in part by getting releases, in part by making it a normative feature. So I want to talk a little bit about the basics of family engagement. I've said to you why it's so important. Let's talk about some of the basics of how you might approach it. Well, here's just another word or two on the rationale. Both families and patients need more explanation of why, how treatment goes, how it works, what the rules are, even such simple logistic things as schedules. But also remember, we do this every day. We know the secret handshake. It's a little odd to everybody else. What is their role? What are they supposed to do? What are the rules of engagement? Important to make that explicit. As I've said, families do have core competence and deep connections, and we need to utilize those and encourage those to blossom. And I think that it is not a competition between emerging teenage and young adult autonomy and self-efficacy and the empowerment of families. I think those things are compatible. And so figuring out how to make those concurrent goals that can blossom together. Remember, the kids may think that they're all grown up and they're ready for independent living skills and they're ready to take care of themselves, but we know they're not. It's developmentally normative, though, for them to have 1 foot in childhood and 1 foot in adulthood. We want to encourage them to make that transition, but both because they are young people and thereby immature, but also because more than the average young person, they are immature because of the developmental toxicity of substance use. They are even more immature than the average person of their age. And so it's important to be able to work on empowering families. Now, as I say, the families come to us up to their ears in alligators, and they tend to be polarized between these two opposites. On the right, I'm helpless. I've tried everything. There's nothing I can do. Don't ask, don't tell. I don't want to know. On the left, it has to change tomorrow. I'm not taking this another minute. I won't put up with this. I'm going to throw you out. I'm going to cut your head off. I'm going to go for the nuclear option. And that's not sustainable. And parents will constantly bluff. I'm going to throw you out and then not do it. I'm not saying it's good to do it, but it's even worse to bluff about something that's not realistic. But you know, and I know that neither of these seesaw polar opposites, and most parents go back and forth between one and the other, are optimal. We want something in the middle. And that kind of persistent, consistent, medium, authoritative, but not authoritarian, non-punitive parenting is very difficult, but you can teach it. And that's part of what we do when we engage families. One of the ways I told you I would talk about is a model that we've been developing over the past few years. We call it Youth Opioid Recovery Support, or YOURS. And it's got components of assertive outreach. Similar, those of you who work in psychiatry know about assertive community treatment for schizophrenia and other chronic and persistent mental illness. People go out into the community, not waiting for people to come into clinic. It's a standard model, ACT. So stealing from that playbook, how do you use assertive treatments and adapt them to youth with OUD? We do home delivery of injectable medications, either injectable naltrexone or injectable buprenorphine. And we've got grant funding to give incentives for receipt of medication. Lots of these things are hard to do without grant funding, but I'm going to focus on the family involvement component, which I think doesn't require this fancy protocol and extra grant funding, but I think can be incorporated incrementally into anybody's treatment with a little attention. And I'll give you just an example of why I think in MOUD in particular, family involvement can be so important, so transformative. This vignette of a young man with injection heroin, injection fentanyl use, who's had a bunch of inpatient detox admissions over a couple of years. And it's a bit of a revolving door with him. He's gotten several doses of extended release naltrexone while an inpatient, with the expectation that this is the beginning of an ongoing treatment, set you up with outpatient treatment to continue the injectable naltrexone plus IOP plus other things. But he never follows up, never comes back for a second dose, relapses, and then months later is back in crisis, back in detox. This time, he's enrolled in the YOURS program. And so a month after, he gets his first dose of injectable naltrexone, and the mobile team who's involved, grandma, who he lives with as the treatment significant other, family engagement participant, collaborator, partner, come to the house, say, it's time for your shot. And he says, you know what? No, thank you. I've changed my mind, just as he's apparently done many times before. I can't tell whether he says no to the medicine because he's already relapsed, because he's contemplating relapse and tempted to use tomorrow, because he wants to keep his options open to use, or because he's still committed to abstinence and recovery. He thinks he's invisible and he doesn't need my stinking shots because he's going to do it on his own. I can't read his mind. I don't know. But either way, he says no. The difference this time is that I got grandma on my team. And grandma says, you live in my house. These are my rules. No is not an option. You're getting the dang shot. And grandma has juice I don't have. Grandma has juice that the therapist, the nurse doesn't have. Grandma has love, connection, persuasion, moral authority, whatever grandmas have. And he gets the dose. And in this case, he gets 6 consecutive doses as part of the 6-month duration of this particular study initiative duration. Now, not everybody does that well, but this is the idea. This is what we aspire to in having a family partner who can be part of things. This is another case vignette, not OUD, more cannabis use disorder, but this could be a high school student. In this case, it's a community college student with alcohol and cannabis use. Maybe he's recently experimented with opioids, but not required for this vignette to have the power it does. And he says there's nothing wrong with weed. They treat me like a child. They're always screaming at me dramatically. I'd just as soon go off and live on the street. Not that that's realistic, but you know, that's what a kid will say in the heat of the moment. And they say, oh, he doesn't get it. If he keeps this up, he'll never get anywhere. He lies and steals. We're done. And so what we want to do, what you want to do, is try to begin a process of discussion and negotiation, teaching the parents about setting rewards and consequences for behavior, getting the kid to participate in that, giving input to the goals, learning rules of communication and negotiation. That's a heavy lift. It's hard work. And it's easy for everybody to get discouraged. The parents say, we don't have time for this. You say maybe we should say as part of the consequences that we won't drive him places. Well, that's stupid and naive. If we stop driving him, then he wouldn't go to school. So I can't do that. You say maybe we could take his phone away. Well, if we take his phone away, we won't know where he is. And that'll be even more dangerous, you idiot. And besides, he says he's going to run away if we put any pressure on him. So what's the point? He doesn't listen. We might as well just throw him out. Obviously, that's not logical. But you've heard this before in the heat of the moment. It's so easy to get catastrophic and escalate and up to your ears an alligator and jump to the nuclear button. So part of it is slowing everybody down, taking a breath. Let's go through it. Let's see if we can negotiate. Again, the patient's rejecting. I don't want to meet with them. They don't need to know my business. They'll never give me rewards unless I'm perfect. That's part of the common mistake. We'll give him a car when he graduates from high school with straight A's. Whoa, 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 whoa. That's not how to get a mouse to run a maze with cheese. They need a little bit of cheese every day for doing something in a digestible chunk that they can accomplish. Can't wait 4 years for an impossible goal. But again, that's part of your teaching. So part of the issue in trying to do a better job in family negotiation is rules of the road for communication. How do we deal with the confidentiality barrier? Do we follow rigid limitations on disclosure and say, Mom, Dad, Grandma, I can't tell you anything? Or do we say, kid, your confidentiality is irrelevant to me. Of course, I'm going to talk to your parents and tell them what they need to know. Shut up. Well, those are cartoon, polar, rigid opposites. Of course, I think it's neither. I think it's about getting to yes for agreement and consent to open communication as a standard part of treatment. And you got to do that. You got to do that up front and negotiate that up front. So you can't talk to my family. Okay, I won't talk to your family. Huh? You can't talk to my family. Oh yeah? Watch me. How about this as a more nuanced approach? You can't talk to my family. Well, what would you like me to say when they call? Because they're going to call. Should I say, little Johnny has forbidden me from talking to you and he doesn't want you to know anything? What is that going to tell them? How about we talk to them together? And so part of doing the role induction and setting the tone for this is role playing, is saying, I'd like you to get better at telling them, but I'll run interference. By the way, that's a huge points earning trick. If you can be in a room with everybody together and say, ma'am, how about if you say it this way? That was a little harsh. Did you notice that he winces or he clams up when you say it that way? Whoa, you said that to my mom? Again, you do it in a digestible way. Maybe you've met with mom beforehand to get her ready and prepared so she doesn't feel, like she's called out. But either way, if you can run interference and show them that it doesn't have to be as punitive as they're used to, that it doesn't have to be explosive, that you can accomplish some change for them and get them parent points and teach them that the accumulation of parent points is actually good for them, then you've accomplished something. So you normalize it. Yes, everybody signs releases. Yes, we have open communication. This is just what we do. It's not you. It's not that you're a terrible patient or you're a terrible parent or that this is special because you guys need this remedial work. This is just what we do. You don't want to have them come in. Well, the worst that can happen is it goes poorly and we don't do it again, but let's see what happens. By the way, don't you want their help? You live with them. They're supporting you financially. They do give you some goodies. Wouldn't it be better if they trusted you? You're complaining to me they don't trust you. Maybe I can help with that. What if I could get them to back off a little bit? And by the way, it's very hard to keep a secret forever. Oh, Dr. Fisherman, you have no idea how good I am. Yeah, no, I can tell you're pretty good, but nobody's perfect. The truth will often sneak out. And then it'll be worse when you've been caught lying. Won't it be better if you earn honesty points and let's get them to reward that in a way in which you're not in trouble for telling the truth? Oh, that'll never happen. Well, we could try. So these are just some of the things that we work with parents, trying to teach them to do a better job. Pick your battles, know your leverage. You got to give to get. You have more juice than you realize. Keep your eyes on the prize. This is a marathon, not a sprint. One lapse is not a disaster. We're going to keep going. We're going to put up with it. Pick your battles is so important. Don't worry. You got to let some stuff go. You can't have 6 priorities. What's the most important thing? You got to let some of the sass and the eye rolling and the back talk and the cursing go. Which is going to be our therapeutic goal for this week? Reduction in injection fentanyl or that he never cleans his room? I don't know, just saying, you pick. I'm not exaggerating. I have this conversation once a week. But one way or the other, how's it going for you? Is it time to try something different? Are you tired of battling? Give this a try. All right, so we're at the hour. Let's take a moment to talk about family engagement, questions, comments, and then let's take a break and come back and do a deep dive into the case of Brittany as an illustration for using the ASAM criteria for treatment planning and placement matching. But comments, questions?
We had one question from Sabrina that didn't get answered last time about evidence-based SA treatment curriculum that you are aware of for youth that has a family component.
Yes. I will get you guys some resources. There is a SAMHSA published guide, MET CBT 5 and MET CBT 7, and I think the 7-session add-on has some family sessions. The ACRA, Adolescent Community Reinforcement Approach Manual, also published by SAMHSA and by the Chestnut Lighthouse Group in Illinois, has a family component. If I'm not mistaken, Virginia has a state initiative to disseminate ACRA. Is that right? Well, if not, anyway, it's a good manual and you guys could take a look at that. And I'll, if the organizers remind me, I'll get you a good link to get that free resource.
Thank you.
Here's a comment: maintaining strengths-based and not shaming the parents. I totally agree. Parents often feel guilt and shame. So that's part of the enabling message. And they hear that as it's your fault. Got to backpedal on that. And you got to, just like you say to kids, it's 10 strength-based praise things for every one negative critical thing. Hard to do, but critical. Yeah, so if you've done multisystemic therapy or other structural family therapies, multidimensional family therapy, brief systemic family therapy, and other structural-based family therapies, you've heard the arguments, you've been in the trenches, you've done this work in depth. One of the things I want to say about these very involved, high-fidelity, complicated training structural family therapies, and they are great. And if you've had the privilege of being trained in them and actually dug in to do that manualized work, good for you. It's a great skill to have. But a lot of people are put off by the level of training and fidelity and depth that's needed to accomplish those therapies. And I want to encourage everyone that you don't need to go that deep. Lots of these principles and elements of family involvement can be done at a more surface level, and you can go as deep as you want at as much time as you have, but just inviting families into the room, just being welcoming, just having a conversation about communication and drawing on them when you can. The thing I often say to young people is, listen, this is your confidential treatment. I'm going to protect your confidentiality unless I'm worried about you. But if I'm worried about you, I'm going to call the cavalry. And if it's your mom that's the cavalry, let's get her to help. Now, I'm not going to do this behind your back. I'm not going to do this without your knowledge. I'm going to want you to do it with me or do it first if you'll let me. And mom, you're not going to hear all the gory details. You're going to have to trust me. I'll tell you what you need to know, and we'll work out the rules of the road. I've done this before. You can always fire me, but give it a shot. Here's the comment: secrets keep families sick, but secrets certainly happen. So trying to undo the secrets is part of what we try to do. Here's somebody else saying MST was a good experience. I agree. Here's a resource called Relias. I don't know them, but if you would share that resource with the group, that'd be great. Contingency management. Yes, absolutely worth talking about. For those of you who don't know, contingency management is a jargon term for motivational incentives or pay for performance. The traditional thing that has been studied, most in adults, but some in adolescents, is giving monetary or other rewards of value for producing a negative urine drug test. And there's lots of science behind it. And in many, many research studies, it proves to be effective while you're doing it. It seems not to continue to generalize after you stop doing it, but it's good while you're doing it. Part of the problem is we haven't learned how to broadly adapt it and have uptake and dissemination into standard treatment for Medicaid nickels. So who's going to pay for it outside of a research grant? So people are working on that problem, and some states and some Medicaid programs have begun to tackle that problem. Part of the issue is that broadly CMS, and I don't agree with this, but I'm not CMS, CMS has been skeptical of incentives as possibly being fraudulent or subject to corruption, even though it is an evidence-based treatment. So stay tuned on that. I'm hoping they're going to reform that. We use contingency management in a different way in our Yours program. Rather than giving incentives for the negative urine, we give incentives for the receipt of the medication dose. That's been less well studied, but it's a similar idea. That is, create a paired reward with something that is pro-treatment. And we can use these principles in our family coaching as well. Mom and dad say, well, I'm not made of money. I can't pay them. I can't spend hundreds, thousands of dollars on their negative urines or on their treatment rewards. And I've already spent thousands of dollars on bailing them out and their lawyers and on crashed cars and blah, blah, blah. Right. Not asking you to pony up a whole bunch of cash that you don't have. What I'm saying is every family has some goodies that it's already using. What are the goodies in your household? Is it family dinners? Is it special meals? Is it treats? Is it family time? Is it going to the movies? Is it, God forbid, cigarette money? I don't know, use of the car, whatever it is. But now keep doing what you're doing, but link it to treatment goals and say, these rewards will be forthcoming when you do blah, blah, blah. Negotiate that up front. Is the blah, blah, blah going to treatment? Is it getting the medicine? Is it having the negative urine? Is it, you choose, but begin to be progress savvy about the goodies and the bennies. Other comments, other questions before we break? All right, hearing none, come back in 10. Sound good?
I'll start the timer.
All right. We are back. And let's get started. This next element in our discussion will be an attempt to bring these elements together, all 6 assessment dimensions, assessment for severity and treatment need in each dimension, constructing and proposing elements of a treatment plan corresponding to the assessment and severity and need in each dimension, and then trying to put that together in a placement decision for treatment matching. So we'll run through a case in some crude detail. We won't know all the details, and part of the discussion is what else do you want to know to be able to clarify, get more information, and zero in to get what you need. And then we'll also run through a series of alternate scenarios, modifying elements of the history as in what ifs, both in terms of baseline information and future developments in the course, just to get a feel of the dynamic revisiting the assessment scenario over time or with different elements to see how it affects our decisions about needed treatment and placement decisions. So Brittany is a 16-year-old teenager, longstanding daily cannabis use, binge alcohol, really not much treatment. As you'll see, she lives with her grandmother. She's had a long history of poor academic performance, truancy, chronic involvement with juvenile justice, some undiagnosed difficulties with mood and behavior. Grandma calls her out of control. That's the overview. Now let's dive into the details, breaking it down into the components. So you've done a history, you've asked her a bunch of questions, both open-ended and closed-ended, and now we're reorganizing it. And we'll go through first in terms of the topics of assessment, and then we'll recalibrate into assessment dimensions. So in some way emulating the way that a natural history goes. You don't necessarily talk to the person dimension by dimension in constraining the conversation. You talk to them as you talk to them. Maybe you've got a form, maybe you check off the boxes. And you usually do that by categories and then reorganize into categories and then maybe reorganize into dimensions. So here let's go. So her substance use history is that she had onset of cannabis at age 12. By 15, she was smoking daily. She began using alcohol at 13 with sporadic weekend binges to severe intoxication. That's the typical teenage pattern of alcohol. It's not daily morning drinking the way it is for older people, but it's these sporadic weekend binges. She has experimented here and there in a minor way with other substances. She can't tell you exactly, yeah, once I took a pill of this or a pill of that. That hasn't been a regular occurrence. Several months ago, she was in detention for a couple of weeks and was abstinent by confinement. A few months ago, she was referred to SUD counseling, but she only went to a couple of sessions, and grandma says they couldn't make her attend. The family background is that she lives with her grandmother. Father's been incarcerated with little contact, and mother is on the streets, so grandmother is the primary caretaker. Her personal history is that she's alleged that she was molested by a neighbor at age 9. No reason to doubt that, but there wasn't legal action. She's been sexually active since age 13 with 8 lifetime partners. She currently has several partners and is not using protection. Oftentimes, that sex is when she is intoxicated and disinhibited. She's had poor school performance, has not been an academic performer. She had to repeat 3rd grade. Grandma recalls she was told that she was a slow learner, but has not had special education services in particular. She's had suspensions for disruptive behavior. That's escalated, especially this past year. She's supposed to be in 10th grade, but she's hardly going. So it isn't clear that she's going to get to the 11th grade at the pace that things are going in. And most of her peers and acquaintances are involved with drugs and delinquent behavior. So she has this deviant echo chamber peer group. Her medical history is that she had some childhood asthma, unclear how active it is. She's been treated in the past for chlamydia. One time she had a spontaneous abortion, and she complains of chronic stomach aches, but hasn't had much of an evaluation for that. She was arrested for controlled substance possession on school grounds at age 14. Those charges were dropped, but she did have school discipline. She received probation at 14 for assault when she got into a fight at school with another kid. She's had a probation at age 15 for a distribution charge, and then she was in detention for a couple of weeks when she took grandma's car and was charged with violation of probation, unauthorized use of a vehicle, car theft. Her psychiatric history, she has not had a formal evaluation, so we don't have a diagnosis or treatment, but she's had chronic symptoms of inattention and hyperactivity since childhood without treatment. Grandma talks about emotional lability, dysphoric mood, difficulties with emotion regulation, tantrums and explosive temper. These have been going on since childhood, but they're certainly worse over the past few years as her substance use has escalated. She's ungovernable at home. She stays away late, doesn't follow grandma's curfew, and at least on one occasion was gone overnight. She has a disrupted sleep-wake cycle. Is it insomnia? Is it that she sleeps and naps in the day when she's not going to school? Is it both? She says cannabis helps her chill, calms her down, helps her with her temper. If she's smoking, she's not fighting with her peers. Not saying that's accurate, but that's her story. The school has attempted to get her into school-based counseling, but that hasn't been successful. She's not, as I said, had a formal psych evaluation. And when she talks about the brief time that she had abstinence from cannabis by confinement, not because she wanted to cut down, she says that her insomnia and irritability were worse. So here's this information. It's a big jumble. I'm sure this is reminiscent of many young people that you've met and encountered over the years. So what do you do with this kid? What do you see as her high priority treatment goals? And there's a dozen of them, right? 24 of them. So how do you prioritize them? How do you sequence them in a community treatment program? Where do you put her? What are the considerations for level of care placement, both in terms of ideal aspiration and then constrained by real world constraints and availability according to your local resource map and what you can get? And what's your next step? Just some questions for consideration. You know, what would you best do? What's your next step? Because she's at high risk, she should be in detention with a special behind the walls services where her out of control status could be addressed more safely. She needs to be locked up. She's at risk of being in trouble with the law. She's on probation. She's had detention before. Why not give her detention and services there, if they even exist in your community? Because of her high risk and imminent danger of harm, she should be immediately placed in a residential treatment program. Do not pass go, do not collect $200. Because of her lack of cooperation, she should be in a level 1 OP program till her motivation improves, because she's not going to cooperate with anything more intensive. Because of her need for higher intensity treatment in the community, she should be referred to a level 2 IOP program. Because of her need for sustainable accountability and containment in the community, she should be placed in a juvenile justice structured program like a drug court, if one in fact exists in your community. I don't think there's a right answer, but I do think there are some of these answers that are better than others. I don't think she needs an immediate punitive detention. I don't think there's evidence that she's committed some high-grade new crime or that she's at imminent risk if we don't lock her up today, tomorrow. I think there's an argument to be made for residential treatment, and we'll get more into that. But again, that's going to depend on some of the details of imminent risk and whether she might succeed at a less restrictive placement. And the other things are worth considering, depending on the details and how things progress. Again, let's get into the weeds of working through the ASAM dimensional assessment. But before we do, what's the treatment plan priority? Get her to admit that her cannabis use is out of control, so that she'll be motivated internally and ask for treatment. Engage her in treatment by building therapeutic alliance, perhaps by offering to help her get out of trouble. Explore the trauma that is probably the underlying cause of her problems. Help her address her cannabis withdrawal, which seems to be getting worse over time. And we had an example of how it flared while she was in detention and involuntarily stopped. Again, it may not be a right answer, but I can tell you that some of these are better than others. I think that number one is a misdirection. That is, she doesn't have to get it and be highly motivated before we engage her. That's not the way usually young people have insight and treatment progresses. And I think number 3 is a misdirection. We don't know that trauma is the underlying cause of her problem. She seems to have had some trauma. Maybe it's a big deal, maybe it's not. I mean, certainly it was bad for her then. Whether it's persistent in causing trouble or not, we don't know. And whether it should be the top priority, we don't know. So I think that jumping there is not right. But I think 2 and 4 have merit. I'm not saying they are the priorities. But again, we want to think about how to sequence these things. What are the things that will most likely be able to engage her on her terms? What are the things that are most likely quickly to show her some progress so that she's interested in what we have to offer? All right, so let's go through it dimension by dimension. In dimension 1, what is her acute intoxication and withdrawal potential? Well, we know about cannabis withdrawal. The primary symptoms there are insomnia and irritability. Not an emergency, not life-threatening. Doesn't need to be in a hospital the way it would be maybe if it were high severity alcohol or benzo withdrawal. Doesn't need to be in residential treatment the way it might be if it were opioid withdrawal. But still needs attention, right? So what are the treatment service needs? She needs some education about withdrawal. How does it affect her sleep? What's her sleep pattern that contributes to her disruption of a sleep-wake cycle, staying up all night, sleeping in? Teaching her that insomnia is a potential relapse trigger. And what can we do about that? Besides teaching her about sleep hygiene and educating her that there is such a thing as cannabis withdrawal, which will probably be helpful, we could offer her a temporary sleep aid, Benadryl, Trazodone, what have you. And again, show her that we can have some immediate impact on something that matters to her. Where does she need to get placed? Well, there actually is no constraint on the placement decision based on treatment needs in this dimension. That is, this treatment need could be met at any level of care. So the least restrictive would be a level 1 outpatient. But if she ends up in the hospital, if she ends up in residential, if she ends up in IOP, that's fine too. But this dimension doesn't drive the level of care placement matching decision. Dimension 2, she doesn't have any acute problems. She's not ill. Most of our adolescents are not medically ill. She has had some asthma in the past. Let's look into that. Does it need immediate treatment? No reason to think that. Smoking cannabis probably ain't good for it, but that's not today's problem. She's been lacking general health maintenance. She's had an STI in the past. Let's check that out. Let's treat her for it, but that's not an emergency. Sexual risk behavior counseling, because she's had high-risk sexual behavior. She continues to have high-risk sexual behavior. We don't want her to get in harm's way that way. Once again, these don't drive the placement decision. These things could be done at any level of care. These are not the priority for today, tomorrow. Let's get to them. They're important, but they don't drive either the placement decision or the priority sequencing of immediate treatment needs. Dimension 3. Well, here she's got more going on. She has a significant mood disturbance. It hasn't been evaluated. There's no imminent danger. We don't think that she's homicidal, suicidal, at risk of imminent danger from lack of self-care. She's not sleeping out under a bridge. She's not malnourished. But for sure, her social functioning is significantly impaired in many of the typical adolescent youth domains: school, legal, family. And her emotional behavioral dimension 3 symptoms have caused lots of interference with addiction recovery efforts. She doesn't go to treatment. She doesn't show up at school counseling. She stays out at night. She's not organized. She's chaotic. She's got deviant peer group affiliation. That's only going to get her into worser and worser trouble. She has a self-professed psychological benefit of substance use. That fact comes up again in dimension 5 as a relapse continued use provoker. And although she's not in imminent danger, sleeping under a bridge, exposure, freezing to death, she does have some degree of impaired ability for self-care, characterized by ongoing sexual risk behaviors, hanging out with young men and not using sexual contraception protection, so that she is at risk. So what does she need? Well, the first thing she needs is an evaluation. She needs some psychiatric assessment to get into the details of what's all this jumble of symptoms. Does she have major depression? Maybe yes, maybe no, but let's look at that. What treatment does she need? Does she need psychotherapy? Does she need an antidepressant? Does she need structure? She certainly needs some programmatic treatment setting for implementation and close monitoring of whatever psychiatric treatment is determined as needed by that evaluation. Whether it's medicine or therapy or both, you can predict that it's not going to be as simple as, we think you should go see a therapist, you should take this medicine, have a nice life, come back in 2 months, tell us how it's going. That's not going to cut the mustard here. In order for this to happen, especially given her previous treatment utilization or lack thereof track record, we need moderately high intensity structure to support that, to make it go, to implement it, and to assess response, adherence, implementation in real time. So where can you do that? Well, probably that can be done in a level 2 intensive outpatient or day treatment program that has baked in integrated psychiatric treatment, or that is provided through coordinated psychiatric service referral. Is she severe enough to need residential? Well, maybe you could make that argument. Is she on the borderline there? How, maybe that we don't have enough detail. How much trouble is she getting in? How much is the fighting? Is it every day? Is it once in a blue moon? How much is the running away? Is it every day? Is it once in a blue moon? So we need some more details to see how dangerous the mood disturbance, the behavioral disturbance in dimension 3 is. You could convince me, if with further evaluation, it looked more dangerous, it would tip me into pushing towards residential. If there were lack of progress at an initial level 2 placement, you could easily make the case that this isn't working, we need to up the intensity. We're concerned that structure and boundaries and supports in the home environment, fast forward to dimension 6, an overlapping dimensional assessment here, as many dimensional assessments are, may not be up to sustaining outpatient treatment. Is she going to go 2 times a week, 3 times a week, every day, whatever it is? Is she going to get there? Is she going to run away? Is grandma going to be able to get her to go? If she doesn't, will there be further deterioration of social functioning to get to the point of imminent danger? Yeah, that's plausible. But where I come out here is we should probably start with trying the less restrictive and see how it goes, barring other information, barring that things don't go well. Dimension 4, readiness to change. Well, she's clearly pre-contemplative or pre-contemplative. She sees herself not as having a substance problem, right? She sees herself as having a probation officer problem. And she doesn't want to change in terms of her substance use. She'd like to get out of trouble, but she doesn't connect the dots. So what does she need? Well, she needs some degree of medium to high intensity treatment dose, including frequency and a programmatic milieu, to help her through the stages of change, support motivation, to work first on extrinsic motivation, hopefully over time to move towards intrinsic motivational enhancement, including the usual things that you know about with motivational interviewing and motivational enhancement therapy and functional analysis of the pros and cons. Maybe there's juvenile justice leverage that can be applied. How active is her probation officer? Some probation officers say, call me once a year, I'll be satisfied. Others are more activist and are good case managers. You don't know. But can we work with the system, with grandma, to create leverage, to help motivate her? And where can that be done? Well, I think it probably needs some level 2 intensive outpatient more than once a week, some intensity, some treatment milieu, group with other kids, where if you can create a positive recovery environment. I would argue that level 2, either intensive outpatient or a day program, would be the appropriate level of care, treatment matching placement. Dimension 5, well, she's actively using, so we're not talking about relapse, we're talking about continued use potential. She had a very brief involuntary abstinence by confinement, but she had no appreciable acquisition of recovery skills. By the way, this is a thing you see more with adults in carceral settings, less with kids, but you do see it with kids who are in juvenile detention. But the idea that people say, well, they haven't been using because they've been locked up, maybe they don't need intensive treatment. Well, you're not exactly getting recovery skills while you're locked up, right? You're involuntarily abstinent by confinement, but that doesn't make you less likely to relapse. So I think that's a specious false argument. But anyway, she didn't get recovery skills. And besides, she's back out from detention and she's using. And she's already not been amenable to a level 1 treatment to prevent continued use because she wouldn't go. By the way, you don't require fail first. That's a key principle of the ASAM approach. You don't have to have participated in and failed level 1 to get level 2, participated and failed in level 2 to get level 1. You have to just make a rational argument that it won't be suitable. But anyway, what does she need? She needs near daily monitoring and structure to overcome this pattern of habitual use and impulsive behaviors and susceptibility to use and relapse triggers. And as part of that relapse prevention intervention, she needs all these CBT things: relapse prevention, trigger identification, refusal skills rehearsal, guidance and support of alternative pro-social leisure activity. And those are going to require typically, if she'll do it, more than once a week. That's going to need a programmatic milieu, multiple weekly sessions. So some kind of intensive outpatient or day program level 2 setting. And dimension 6, grandma's not toxic. Grandma's supportive of treatment. Grandma endorses what you want to do. Grandma's on your side. But you suspect, based on the past history and your discussion with grandma, that she lacks the personal resources to effectively sustain the treatment. The peer group is predominantly substance using for now, so you're not going to get support there. And so part of what she needs is family intervention. We spent some time talking about how to do that. Grandma needs some coaching on monitoring, on home behavior negotiation, on utilization of services and system, including possibly taking the juvenile justice system tiger by the tail. Of course, families are reluctant to do that because once you're in the system, you're in deep. But how to apply leverage. And these are things that are going to be met by a placement at level 2 again. So overall, average all those things up, some level 1, some level 2. Level 2 predominates, and that's where I would start. Now let's go through a sequence of alternatives, either because we see how the case unfolds over time or because we switch up on the baseline characteristics. So we enroll her in IOP, let's say, and maybe she's come to a session or 3, but she runs away from home during the first week or the second week. What should we do? Throw in the towel, this isn't working, refer to residential treatment, as I said, tipping the balance on whether this level 2 placement will work. See if we can get her PO to violate her probation, get a warrant, and see if there's a possibility of probationary sanctions, maybe even detention as a response to her ungovernable behavior and lack of cooperation. When she does come back to grandma's a day later, try again. Encourage her, encourage grandma. She did, after all, come to the program. Let's see if we can debrief what she was up to when she ran away and give it another go. Send her to the emergency department for emergency psychiatric hospitalization since she's obviously a danger to herself. Again, there's never one right answer, but you could make the argument that the writing is on the wall. This isn't working. She needs a higher level of care. So I don't know, if you have all the levels of care, go from 2.1 day IOP to 2.5 day program, or go to residential treatment if it's available. But we're not persuaded that one episode of running away from 24 hours, if that's the only facts, necessarily constitute imminent danger, but it's on the table for discussion. I don't think that violating her probation and going to a punitive justice system response is going to help her much. I do think that trying to re-engage her in debriefing and seeing if you can give it another go is worth considering, but I don't know how many rounds of trying again if she keeps running away and keep not coming are worth doing. I don't think that an acute psychiatric hospitalization is going to change this runaway behavior and stabilize this. And I don't think we have evidence that this itself constitutes imminent danger for a psychiatric hospitalization. All right, so part of the program at the IOP is that she gets a psychiatric evaluation, either because it's part of the service delivery as integrated program, or because you do it by referral with coordinated care. And the doctor thinks she has major depression. Doctor recommends adding CBT therapy, adding an antidepressant. But she says, no, thank you. I'm not crazy. I don't need your stupid pills. Not an uncommon response from a teenager. What do? Use an MET approach to try to engage her in a discussion of how to deal with her anger problem. That is, she doesn't think she has depression. Depression's an awkward term. Oftentimes people hear the word major depression and they think that must mean I'm sad. But most teenagers with major depression don't have sadness as much as they have irritability or anger. So focus on your anger problem. You get in fights. You don't like that. You don't want to be in trouble. How can we help you with that? What are the pros and cons of medication? Let's think about it. No, you don't want to do it today. I get it. It's not an emergency. No, we can't make you, but we encourage it. How can we help you learn more? What would you like to know about medicines? Let's go over the pros and cons. What would it take to get you there? Tell her that if she doesn't take the medication, she can't graduate from the program and she'll probably have to go back to tension. Get her grandmother involved in trying to persuade her to consider the medication. Tell her that she can use whatever tools she wants: medication, therapy, self-control, superpowers. Whatever you do, it's okay with us, but you better get yourself together because you can see where this is going. How can we help you? We've suggested one tool. You pick the tool you want, but we got to make progress here. Tell her that, well, yeah, you're probably making the right decision refusing the medication since pills can't fix everything, and you just need to get a handle on the underlying deeper issues. Again, no right answer, but I think 5 is not right. I think threatening her, number 2, is not right, but I think 1 and 3 and 4 have merit depending on the details. Give her control. Say, if this, you don't want to try this, try something else, but we really think you need to try it. How can we help you learn about this? What would it take? And certainly getting grandma involved. All right, in an alternative scenario, it's not just that she's got emotional dysregulation and behavior problems and fighting. She's been suspicious. She's accusing other youth of listening in on her in group or on the telephone. You get the sense that maybe she's responding to invisible stimuli. She sometimes is silent and not responding and looking around the room. And when you ask her stuff, she says, not talking. You all are trying to get me in too deep. So now we're starting to wonder if there are psychotic symptoms. Is this major depression with psychotic features? Is this a cannabis-associated psychosis? But we're clearly seeing a higher severity of psychiatric condition. What should we do? Refer her to residential treatment because of her very high risk. Arrange for psychiatric hospitalization. Just see how it goes. No need to do anything different. prioritize the psychiatric assessment and treatment, which now was always a big deal and a high priority, but now it's really urgent, and or say, well, you can't come to our program because we're not a dual diagnosis program. We don't have a psychiatrist on grounds. You can't come to us. Again, no perfect answer, but I think that 5 is not right. Let's try to do something about her. 3 is not right. We definitely need to do something about this. And I think for sure prioritize the psychiatric assessment, but if you're concerned, here now there may be grounds for psychiatric hospitalization. In many communities across the country, good luck with that, getting a bed, I get that, but that's a possibility. And if there is residential substance use treatment with integrated psychiatric treatment, that might be a way to go. But certainly the urgency for psychiatric treatment, including antipsychotic medication, bubbles up as a high priority any way you can get it. In an alternative scenario, she has had numerous previous failed attempts at treatment at the OP and IOP level. It's not just a casual attempt to get school counseling or once she was referred to OP. It's a pattern of not going, not succeeding. What would you do now if that were part of the history? Refer her to residential treatment, explore with her what was helpful or not about previous treatment and the possibility about doing things differently. Not accepting her into the program, she's too severe, she won't succeed, go shop someplace else, or do nothing else differently, monitor her progress, see how it goes. Well, I wouldn't reject her number 3, but I think 1, 2, or 4 are all worth debating. And remember, I said that you could maybe be on the fence about should you lead with a placement to residential. This is starting to tip here. You've now got lots of examples of why OP and IOP are unlikely to be successful because now you've got real concrete evidence that it hasn't been successful in the past. Maybe if residential is available, now you're thinking more in that direction. In an alternative scenario, her primary substance is not cannabis, it's opioids, heroin or fentanyl. What should we do differently here? Refer her to residential treatment, start her on relapse prevention medications, MAT, MOUD, reject her from the program as she is too high severity, shop someplace else, or do nothing differently, just see how it goes. Well, I reject number 4. You definitely have to address this, and you need to address it in a medication forward way. So one way or the other, this is a person that you've got to start on relapse prevention medications, whether it's buprenorphine, whether it's detox towards naltrexone, doesn't matter. But relapse prevention medications have to be part of the tool set, and you do it wherever you can do it. If you can do it at IOP, that's fine. If you can do it by referral to concurrent medical services through primary care, that's fine. If you can do it through residential treatment, that's fine. We had a little discussion earlier about your local resource map and how there are workarounds maybe with psychiatric hospitalization or medical hospitalization. In many communities in the country, it is a resource that is difficult to find, but the key is has to be prioritized. In an alternative scenario, her primary substance is methamphetamine, or maybe it's cocaine, but a high potency stimulant. What should we do? Same set of alternatives. Refer her to residential treatment, start her on relapse prevention medications through the program, don't accept her, do nothing different. I think, again, I would reject 3 and 4. The problem with relapse prevention medications is our medication tool chest for methamphetamine and cocaine are nowhere near as advanced as they are. We haven't had time to discuss them. That's a whole other discussion for another day. We do have some off-label medicines. They're pretty good. They're not great. They haven't been tested in teenagers. I use them, but I can't say they're standard of care. So you do have to be concerned about the imminent risk and progression of high severity, harder substances like methamphetamine and cocaine. For me, they would be grounds for considering strongly residential treatment if it's available. All right, so treatment progresses. She misses several days during the second week of the program and says, you know what, I've been using cannabis and alcohol over this past weekend. What should we do? Discuss her attendance, debrief her use, continue to try to engage her, but hold the course. say it's not working, she needs to go to residential treatment. Consider a revision of the treatment plan, perhaps re-examination of what motivates her, increased intensity of services, increased involvement by grandma as part of a slight modification of the treatment plan. Discharge her, kick her out, since this program is only for motivated youth and clearly she can't take advantage of it. Well, I think 4 is wrong. I think 2 is premature. Remember, we expect 3 steps forward and 2 steps back. 1 weekend use. She's coming. Maybe she's making some progress. Let's debrief. Let's reassess. Let's modify the treatment plan. But I think we should press on with the expectation that she's been engaging and we can hope for further engagement. Maybe yes, maybe no. Let's see over time. Well, rather than just missing a day and using once, she misses more days than not, and she hasn't cut down on her use over a month. So what should we do? Discuss her attendance, debrief her lapse, continue to try to engage her, use juvenile justice leverage if we can get it from the probation officer, consider revision of the treatment plan, including priorities, involvement of grandma, etc. Throw her out. Well, we could keep going, but we have more and more evidence that this isn't going well. So I think certainly a revision of the treatment plan, but now maybe it's not a minor revision of the treatment plan. Maybe it's a bigger revision of the treatment plan. Maybe it's an escalation in the level of care. Maybe it's a time to sit down and talk turkey. And if you can't turn this around and increase your attendance or do XYZ, then we're working on a residential treatment referral. What would you like to do? If you'd like to avoid that, then here's what you can do. If you would like to do that because you recognize, or grandma, because you recognize that this isn't working, let's try to arrange that. She's not coming at all. Grandma says, I can't make her come. The same set of considerations, but even more evidence that this isn't working, that we have to ratchet things up and use more leverage, including possible residential treatment if it's available, including possible juvenile justice leverage, again, if it's available. Here's an alternative with progress, and she's doing well. She's cut down. She's even progressed to abstinence within the first month or two. She went to a couple of 12-step meetings on your advice. At first, she thought they'd be stupid, but she says, well, it's not as stupid as I thought. She's got, say, 4 weeks of negative urines under her belt. What should we do? Discharge her since she's ready to graduate, ready to go, have a nice life? Praise and encourage her while continuing to hold the course and work on consolidating and sustaining treatment progress? Reward her by decreasing the intensity of her probationary restrictions if you have that influence on the PO or on the program requirements by saying, well, you're doing well, maybe you don't have to come as often if she finds it burdensome. Since it is too early for her UDS to be negative, marijuana lasts a long time in your system, she's telling you she's abstinent, but she still has cannabis in her urine, so you don't know whether she is telling the truth or whether she's lying. So before you congratulate her, wait till the urine is negative. Don't count your chickens before they hatch. Well, I don't think you throw her out because a month is good, but it's still more to be done and there's consolidation. I think praising and encouraging her, whether or not you have the urine, makes sense. She says she's not using, take her at face value. You'll get the urine when you get it. Maybe you have quantitative levels if your lab has that, and you can see the numbers coming down. So that's evidence. If you don't have it, that's fine. You tell her, well, listen, we're hoping that it will become negative, but in the meantime, we're so pleased and so proud. And although we don't want to characterize treatment as punishment, so we'll punish you less by requiring you to come to less sessions, do recognize that the average kid sees it as burdensome. And if you can turn relief from requirement into a contingency management, motivational incentive reward, not saying she doesn't have to come at all, but maybe she gets privileges for doing well by coming 2 times a week instead of 3 times a week, 1 time a week instead of 2 times a week, etc. You get the drill. Okay. Just to conclude, the 6 ASAM criteria, assessment dimensions, I hope I've persuaded you, are a nice way of organizing the core principles of assessment, treatment, and level of care placement, that they are a nice way, a useful way of structuring treatment planning based on individualized needs in a bunch of structured different domains. We do care about who goes where. Placement's important. It's a necessity. It's part of the real world. But I think we get ahead of ourselves in the who goes where placement decision. I think the more important thing is to start with who needs what, and then try it at different levels of care. You may be constrained by your local resource map. That's a shame. I wish that everybody had all levels of care with equal access, et cetera, et cetera. But to the extent you don't, it's okay to improvise, concentrating on who needs what, where you can give it, and give things a try. Can't emphasize enough, as we discussed when I started with dimension 4, these are all important, all 6 assessment dimensions with their corresponding severities and treatment needs and placement issues, but treatment engagement is a pretty darn good place to start. It's where the rubber hits the road. It's where the preponderance of the work you're going to do with these pre-contemplative youngsters are. They're not going to show up for action. So engaging them, reeling them in on your fishing line, working on progressive engagement is the thing to do. Engage families, adapt flexibly, improvise and try different stuff, and be prepared to change the plan. That's okay. You can't read the future. Have a hypothesis, collect your data, be prepared to be wrong. That's okay. Try something different. Here are hypothetical miracle cures. I wish we could do brain transplants. Kids that are immature, could we give them maturation and new frontal lobes or mature frontal lobes? I don't quite know how to do that. My next grant, maybe. But on the other hand, as much as this is a fantasy, there is an element in which it's not a fantasy, right? Maturity happens. Kids will grow up. If you can keep them alive long enough, if you can engage them, you can get to new brains, to developed brains, to mature spirits, minds, brains. And that's part of why we do the work we do, right? So again, we're pretty much out of time. I thank you for the work you do and for your attention. I'm a big fan of this phrase, therapeutic optimism. One of the things that we do best, and I know you guys are committed to, because here you are concerned about kids and their families, is give people a message of hope, light at the end of the tunnel, never give up. There's always something we can do, more stuff we can try. And nobody ever should be on the discard pile. Nobody is a hopeless case. Nobody is too tough. Not saying I know all the miracle cures, but we always keep trying. And not only does that mean that we have some successes, but we give patients and families that hope so that they can keep working on it. And if people do have a minute or two for a couple of comments or questions, I'm certainly willing to hang around. But again, you guys are busy. If you've got to skedaddle, that's fine. Again, thanks. I hope that's helpful. And I'll hang around for a few minutes if there are questions.
You did have 2 questions in the chat. Let me copy them for you because everyone's blowing up my chat here. What are the opioid withdrawal management levels and what criteria correspond to each?
Well, we don't have time to get into that in great detail, so look into the book. But I would say that for adolescents, if residential management is available, and it isn't always in everybody's community, if a person is having physiological dependence with withdrawal and tolerance, I would err on the side of a higher level of care if it's available, because you can bring to bear the resources of nursing and medical and monitoring and abstinence by confinement while you're managing the relapse, while you're initiating relapse prevention medications. But having said that, it's not always available. And even if it's available, patients and families may say, no, thank you. And so beginning buprenorphine on an outpatient basis is absolutely positive and possible. It's a little tricky. Starting naltrexone on an outpatient basis is even trickier, because you've got to have a washout period during which people are not using while you wait 7 to 10 days before you can start the naltrexone to avoid precipitated withdrawal. So buprenorphine is a more common and easier move. So if you have medical providers, or you are a medical provider, or you work with a medical provider who's learning or has already a sophisticated practice approach to the initiation of buprenorphine on an outpatient basis, you're lucky. Keep at that, keep doing that. And that will help engage a lot of young people who can then, as I keep saying, get reeled into other services once their withdrawal symptoms, their relapse risk, their overdose risk is addressed.
Then there's a question on how often do you complete an ASAM reassess using the ASAM?
There's no rule of thumb there. Part of it, mostly we do it in an informal way. You know, you're reassessing a case, and every time you team a case or talk about a case or reformulate a case or think about a case, in your mind, the more experienced you get, whether or not you write it down formally or go through a formal reevaluation, you're thinking, what's the progress? What have I achieved? What have I not achieved? What stupid mistake did I make? What's the right turn? What's the left turn? How do we reconfigure the treatment plan, either in a little way or a big way? Or am I on the right course? More of the same, change the treatment plan. And it becomes part of the kind of ongoing natural thing that you do. In terms of formal treatment plan reviews, you know, every state has different regulations for different levels of care. Is it every 7 days in residential treatment? Is it every 2 or 3 weeks in IOP? Is it every day in the hospital? You know, there are some regulatory constraints in terms of filling out the treatment plan form. Everybody has a different opinion about whether the actual treatment plan form is really useful or whether it's just a regulatory show requirement. Don't get me started. The key is not, for me, not the form. The key is the actual intellectual exercise of thinking about treatment progress, treatment goals, and what you're doing about it.
And then you had one more question, the one last question about the approaches, MOUD, and yours, maybe some resources. And I just looked back and saw that you had given us a yours main findings addiction handout last time we worked with you, so I can send that out in the know before you get.
For sure. And if people are super interested in that, I can flood you with more paper to wrap more fish than you know what to do with. Because I get all excited about nerding out and, you know, that kind of stuff on it. And you're welcome to it. Just let me know. But that one paper, that main findings that we published in Addiction is a good place to start. And just to tell you that we've been blessed with some funding from NIDA. We're now a third of the way into recruiting a larger randomized trial in the Baltimore area for young adults with opioid use disorder, randomizing them either to usual care or the yours intervention to try to, you know, figure out how to make that go. Then the next step will be, if we can demonstrate that it's effective in a definitive way, how do you disseminate it? How do you pay for it in the real world? How do you train people to do it? And another thing that we've been fooling with, many of you will have heard of the CRAFT intervention, which is a way of engaging families and other treatment significant others to encourage loved ones to get into treatment, even if they're not currently in treatment. So it's a little counterintuitive that at first the loved one, that is the treatment significant other, for young people, presumably the family, would be the designated patient. And the young person says, I'm not going to treatment. You can't make me to go to treatment. All right, mom, let's just work with you to coach you on leverage points, how to get the horse to water, how to encourage that person to get into treatment. They may not be ready for treatment yet, but we're not giving up. And then it becomes parenting coaching, parenting training. That was originally developed as an adult intervention. The guy who first wrote about it, Bob Meyer at the University of New Mexico, was mostly working with adult males with alcohol use disorder and their wives as treatment significant others. But it's now been adapted to many different populations, including adolescents. And one of the things that we've been working on lately is adapting it to the parents of young adults with opioid use disorder. When the parents say, I know this kid needs treatment, but they're not willing. All right, mom, let's just work with you for now. Dad, grandma, let's just work with you for now. And that's new to us. We've worked a lot with families once a kid's in treatment, but learning to work with families when the kid's not present is kind of an interesting thing. If you guys want to experiment with it, I encourage it. I'm early in my learning sequence. Invite me back in 3 years, I'll tell you more. But I think it's interesting because, again, as I've said, I think families are so important and overlooked and underappreciated as a way of trying to engage young people with substance use and substance use disorders. So I'm trying, learning.
All right, well, that looks like all the questions. So thank you very much for your time, Dr. Fishman. I have sent you an email because you promised some resources and I just need a confirmation on that. So otherwise, thank you, folks. I hope you've enjoyed the last few days. Please make sure you do your evaluations and have a wonderful, wonderful Wednesday.
Thanks, everybody. Appreciate your attention. Hope it's helpful.